environment, and then challenge them after fasting them for 4 days. We challenge them with foods, see what type of food reactions occur and what symptoms would clear up in this clean environment. I believe I am the last physician practicing still that was trained in this manner. Dr. Randolph and Dr. Ray both had a unit. Dr. Randolph's fellows have all retired. And then I was director of this unit for over 10 years. And since then, I've been practicing environmental medicine, allergy, and the toxicology. So tonight, we're going to talk about mold and mold exposure and the toxic effects of it. So the overview of the talk will be, we're going to talk about effects of mold exposure. We're going to talk about the diagnostic approach and my thoughts on how to approach this. The effects of the exposure, which can be allergy. People become allergic or exacerbate their allergies. You can have the toxic effects, which is the mycotoxins. You can become infected with the mold spores, and that's in the sinuses or the lungs. The toxins can cause immune dysregulation, either up or down, so you become more sensitive, or it suppresses your immune system so it's less able to fight infections. Then we're going to talk about the treatment and how I approach the different problems that we see, the allergy, the toxicity, or the infection in the treatment phase. And we'll talk about a case study or two. And then as I go through, I'll be talking about different tests or equipment or resources, and that will be listed in the end. So don't panic if you're trying to figure out, well, where's he getting this information from, or how do I do that, or what's the resource? That is listed at the end of my talk. So I appreciate your patience to get to the end so we can discuss those areas. At the end, there will be a time for questions, as Matt said, so I'll be happy to answer any of those questions. So the symptoms of mold illness. Many of you see these chronic type patients that come in your door and you're trying to figure out, well, what's going on with them. And they're complaining of brain fog, neurocognitive dysfunction. They just say, I can't remember, I can't think, I can't get my thoughts together. I'm having trouble functioning. The other main complaint is fatigue, that even though they can run, walk, talk, everything, they just feel that they cannot do any more. Even though if you yelled fire, they could run out the door. They just have this overwhelming fatigue feeling. And we'll talk about that a little more. This type of fatigue versus the fatigue of a true neurological demyelinization type disease, such as MS. The MS patient, you could yell fire and they couldn't get themselves out the door, where this type of fatigue, yes, they have plenty of energy, but they use up that energy very quickly and causes overwhelming fatigue feeling. They get aching, generalized pain. Many of them use the term fibromyalgia. They complain of shortness of breath. If there's an allergic component to it, they may have asthma. If it's not an allergic component, they just may feel breathless. And this is even described in textbooks. One of the textbooks I listed at the end as this breathless feeling with the toxic effect on the brain of the mold. GI symptoms, nausea, abdominal pain, irritable bowel. The vagus nerve is the biggest nerve in the body. It's affected by the neurotoxin effect of the mycotoxins. So you can have numerous GI complaints. You get visual changes in some cases, and then you may have peripheral neuropathy, where they complain of numbness, tingling, crawly feeling. And then many of them complain of insomnia. They just can't sleep. They do not get restful sleep. Now, these symptoms may relate to many different disease processes. And so the big question for us as physicians is, how do we separate this out? How do we make the correct diagnosis and be able to solve the problem for the patient and have effective treatment? So this is where the diagnostic confusion comes in many cases, and we got to figure out what tests are the best tests to use to give us the most direct, specific diagnosis. So I labeled here specific test, non-specific test. This is not absolute, but the specific test is measuring specifically for a particular item. So as an example, we have mycotoxins. That is looking at the mold toxins that are excreted through the kidneys in that individual. And so that's the accumulation of what they've accumulated and now what they're excreting. So that's a specific test for mycotoxins. For allergy, this is intradermal skin test. That is a very specific test for allergy for that particular item, whether it's a mold or dust mite, tree grasses, weeds. The intradermal skin test is the most sensitive of the test. Prick tests are not very sensitive and only pick up IgE type reactions, where molds are mainly non-IgE type allergic reactions. And we'll talk about that in a minute. I do cultures, nasal cultures or sputum cultures for mold or bacteria. And I use the PCR technique, the polymerase chain reaction, just as they're using for COVID. And it looks at that DNA and tells us specifically what mold is present. I do a posterior nasal swab to get that culture and send it to a lab that is named at the end. I look at specific IgE antibodies and IgG antibodies to tell about how the body is reacting to mold and what the body's response is. IgE is typically negative, except in highly allergic people, which have a high IgE, total IgE. So these people will have an IgE of, say, 200, 300, 1,000, or they go in the hyper IgE range of 1,000 to 2,000. IgG is that delayed response that shows exposure. It doesn't tell much about reaction, but if you have IgE response to like Aspergillus nigra, Stachy, Chitonium, you know that person has been exposed to that mold, and I use that as a specific test for mold exposure. Foods play a role in this, as you will see, and many times foods have an IgE component, but they also have definitely a delayed inflammatory IgG component for the foods. Then I use indoor spore counts as a specific contamination count that is in the air that can be measured. And that's important, and it's important it's done correctly. There are labs, many labs that do the spore counts. Some of them only count 25% of the spores. You want a lab that counts 100% of the spores when you do the test, and we'll talk about that later. And then there's indoor mycotoxin, the volatile organic compounds. And it's a chemical, as you well know, and as Matt has described in his prior webinar, is that the mold toxins are volatile organic compounds, and you can measure those, and there's a lab that does that. That kind of helps us decide just how toxic the house is if we're having trouble with spore counts. Now, the more non-specific tests are tests that kind of tell us what's happened to our body. What's the effect of mycotoxin on the body? So we see abnormal SPECT scans. We see abnormal neural quants. We see abnormal metabolic nutrition tests. We see inflammatory markers that are present. We see genetic tests, which is HLA testing, which helps give us guidelines to maybe underlying factors of why the people are retaining mycotoxins, but they don't tell us what is happening. They just say that there is a defect in the processing. So we see HLA testing for gluten sensitivity, and we see genetic tests for phase 1, phase 2 detox pathways. QEEG shows us if there is brainwave abnormalities that may relate to sleep problems, seizure type activities, behavioral activities from the QEEG. We see that many people use a Western blot looking for Lyme. This is a group of proteins that have antibodies, but is nonspecific for the Lyme test. And then we look at overnight oximetry, which says, yes, this person has desaturation, possibly sleep apnea. I use it as a screening test, and then they can have a complete overnight test if they need to. All these relate to health factors that we may need to use to help define what's going on. The specific test tells us what has happened and what is present from a toxic mold exposure standpoint. So we go on to other specific type diseases that may be confusing. As we have antibodies that cross-react with other antibodies. And when you do like an Epstein-Barr test and you use Quest or LabCorp, there's a little disclaimer down at the bottom that says, these tests may be falsely positive due to cross-reaction. And we see that with Lyme and the Western blot and the protein. We see that with Epstein-Barr. We see that with the co-infections. We can see that with Rocky Mountain spotted fever with the antibody test. And then there's other tests out there that are non-CLIA certified labs that we do not really understand what they are testing or how accurate their tests are. So just put that in there as a precaution that they won't lead you astray. Now, the diagnostic concept. What can I verify by using the specific test? If the specific tests are positive, you can pretty well count on that is present. So if you have mycotoxins present, you know they've been exposed to mold. If you have IgG mold antibodies present in a significant amount, then you know that exposure also occurred. The other concept is there's generally one cause to a set of complaints. We see that the antibodies cross-react with other antibodies. You may think there's 3 or 4 different disease processes going on, but usually there's one main one, and that's what we need to figure out as we're treating the patient and figuring out what is the best way and what caused the problem. Toxicity, and it takes precedence over other possible problems unless it's acute infections that you find that need to be treated also, and must be treated first to sort out the non-specific complaints. So you'll have exposure to mold. The toxins affect the mitochondria, which affect the ATP, which affects the energy. And so you can try all kinds of things to try to stimulate their energy, but you aren't going to get that back until you fix the mitochondria and get rid of the toxic exposure that's causing the fatigue in the first place. Here's an example of a 23-year-old male, and it's unusual to see 23-year-old males with toxic mold problems. And this one was seen by other physicians, had a semi-positive Western blot, had a couple positive but not clearly positive, was treated with doxycycline for over a year, did not get better, got discouraged, didn't do anything for a while, then went back, found another physician, was treated with IV antibiotics, a port was inserted and given IV nutrients on almost a daily basis for 3 or 4 months with little improvement. I ended up seeing him, looked at the mycotoxins. In the graph below, he had mycotoxins in significant amounts. Now, granted, he'd been treated and had been out of the mold for a long time, but they were still present. I treated him with oral nutrients to help his liver process. allergy immunotherapy because he tested to be allergic, and hyperbaric oxygen therapy to help heal the tissues, including the liver, the mitochondria, and the brain. And as we can see, over the time of treatment, the toxins decreased. We had a little spike here, but then it decreased. And the same over here. The spike in the end was, he was feeling so good, he decided to take a vacation. And he went and stayed on the beach in a moldy environment, came back, said, I feel horrible. And his levels jumped back up. So this shows the necessity to do serial testing to figure out what is going on with your patient, what their improvement is, and it does correlate with their symptoms in my experience. So he was able to go back to college, finished the semester, did very well, and felt well, and is doing well at this point. So in the evaluation, we don't want to jump to conclusions just on symptoms. In working in an environmental unit, I learned that history was very, very important, as we were taught in school. And so I approached the history from a chronological history from birth. You know, how were they at birth? What happened? Did they have a good APGAR score? Did they have any feeding problems? Did they have croup, colic? Did they have developmental problems along the way? What was their early childhood like? Did they have any health issues? Did they have ear tubes showing chronic infections? Did they tolerate vaccines well? Or did they have problems with vaccines, with fever and illness afterwards? Did they have any trauma as a child? Were they taken to the hospital for a trauma? Were they dropped? Were on the floor? Were they hit by a bicyclist or a car? Looking back to head trauma. Areas in the country where they lived in. Many people have grown up with basements. Basements are inherently damp, and damp basements grow mold. And houses with basements have the furnace in the basement, pulling the mold and mold toxins that are growing and dispersing it throughout the rest of the house. So it's important to find out where they lived, how long they lived there. In Texas, where I am, Houston is the one place that we really look for mold. If they lived in Houston, because of the hurricanes going through, they most likely had a flooded house, damp house, leaky roofs, and mold growth inside. Particularly when they tell you, well, I moved from up north, I moved to Houston, and I felt horrible, and I haven't been the right since. So the types and conditions of housing is very important. How did they function in school? Were they top of the class? Were they having trouble in school? Did they feel sick in the school? Were they better at home and then had headaches at school, fatigue? Schools many times are contaminated with mold. In Dallas, we see that quite frequently. Then jobs. Were there plants in the building? Was the building leaky? Many people get sick at work. I had a group of patients from a town not far from Dallas that worked at the police station. They were all sick with headaches, fatigue, nausea, and we did an indoor air quality test on the building, showed high mold levels, Aspergillus penicillium. The fire chief or the police chief had his office just remodeled with a new HVAC system, the whole inside redone. And so we measured his office and found that it almost had zero mold in it, where the rest of the building was just really contaminated. So it was a great experiment on how to clean up a place and then how contaminated the employees were. They got the place cleaned up and they did a lot better. So with this knowledge of a history, we utilized the history of the chief complaints, look at what their symptoms are, look at the date of onset, where they're living, and take the doctors that they have seen and the testing that is completed and review that lab and the treatments that worked or haven't worked and the resulting effects, and put that all together and then come up with a treatment plan on the likelihood of being exposed to mold. So the question is there reasonable probability of mold exposure with this type of history? Many times we're surprised that we find out other things about that patient that they don't think to bring up. That they were diagnosed, say, with an autoimmune disease back at some point, and that's basically resolved. Or they had chronic infections that they really didn't tell us about that add to their health picture. So once we get the history and understand the history and the possibilities of where they were exposed to mold, either where they lived, in the workplace, or where they even vacationed, it's happened where there's been mold exposures. We want to make sure we rule out other major diseases so we aren't missing something. So we have a differential diagnosis and we run appropriate lab tests to make sure that there's not other systemic, underlying, typical disease processes. So usually this can be done with a CBC, Chem24, make sure that what the thyroid's doing, adrenals are doing, look at whether they have gluten intolerance or celiac disease. I use Saccharomyces, IgG, IgM, to look at leaky gut or inflammatory bowel disease. The gastroenterologist uses this test very frequently to screen as a inflammatory bowel disease screen. And what Saccharomyces is a yeast, and if you absorb that through the intestinal tract, then you know you have a porous membrane in the intestinal tract. Doesn't necessarily mean you have inflammatory bowel disease. If you're gluten sensitive and eat gluten, it inflames the bowel, so you will absorb Saccharomyces through that barrier and you will develop antibodies. So again, it's not an absolute test, but it's a test that helps us look at what the intestinal tract integrity is. Cedrate C-reactive protein. Many of the mold patients are normal in a, say, severe disease process, true infection, autoimmune inflammatory disease. Cedrate C-reactive protein would be positive. Look at IgE to look at their allergic potential. IgG subtypes to make sure they're not immune deficient. If they're immune deficient, then they can have all kinds of other infections. We know they're more prone to mold infections, more prone to candida. And then if they have some type of acute infection, IgM, or they have a monoclonal gammopathy, we look at IgA, IgM, and of course IgG is part of that, and IgE. Then have they been exposed to mononucleosis? And that's Epstein-Barr panel. If it's acute, IgM is positive. The IgGs show past infection and may cross-react with mold IgG antibodies. I had one lady that lived here in Dallas. She loved to travel and retired from IBM, and she swore she had chronic Epstein-Barr because she'd go on a trip, feel good on her trip, come back home, get sick, said, oh, the trip was really hard on me. I think I activated my mono, and her IgGs would go up, but she'd never have IgM positive. I finally convinced her to test her house, and we got a mycotoxin. Sure enough, she had high mycotoxins, and her house had high mold spores. Treated her, and her Epstein-Barr went away. The IgGs didn't come back once we got the house cleaned up and the mold toxins out of her system. Lyme antibodies can be the same way. I typically test for Lyme PCR. That has no cross reaction. And then the Lyme antibody screening usually is pretty consistent and not reacting as the Western blot does to other proteins. So let's look a little more at the specific test. The mycotoxins. I've used real-time lab from the beginning. I've done more than 4,000 tests through them. I find them really consistent and reliable and relative to the patient's symptoms. If a person has been out of exposure for a while but still sick, and the mycotoxins come back low, the question is what is going on? They're sick, it doesn't make sense that it's low, and why are we seeing this and they aren't feeling good? What has happened is that the top layer of the mycotoxins have been excreted, but they retain the toxins in their system. Mycotoxins are complex structures that are lipophilic, that stick tightly to the cells, and it's hard to get them out. So to really see if they have mycotoxins stuck in their system and tied to the cells, affecting the mitochondria, affecting the nervous system, I do a HBOT challenge of 10 hours. I usually use 1 hour twice a day for 5 days, and then repeat the mycotoxins. If the patient is symptomatic, I see these mycotoxins jump up, and I'll show you that graph later on an example, but you'll see them increase. So you know they're excreting the toxins they have saved up. If they don't go up after 10 hours, then I know they're pretty well mycotoxin free, because we're stimulating cell metabolism, mitochondria function, and healing with the hyperbaric throughout this. So it's a treatment, but it's also a challenge. I know many of the doctors do not have hyperbaric present, so they use glutathione challenge and repeat the mycotoxins, and can see the mycotoxins elevate after the glutathione challenge also. I use the IgG mold panel, and there's 13 molds that I have picked to run IgG on that produce toxins. We use the Pharmagen antibody technology. It's the one that's been around the longest, and it's consistent. And if they're IgG mold positive, we know that that exposure has occurred. Just as you get a tetanus shot, you produce tetanus IgG antibodies. You get mold exposed, you produce mold IgG antibodies. So you document that the exposure has occurred. For the allergy testing, then I do intradermal mold skin tests, and I'll show you a picture of how that occurs. I do a nasal sputum PCR analysis if they have symptoms for mold bacteria from Mycogen Labs, which is that PCR analysis. They have a little swab, you just stick it up their nose, swab it around. They try to grab your hand, you yank it out quick, and you'll have your specimen. And in 3 or 4 days, Mycogen can turn those around and have your results for whether mold present, bacteria present. And just now they are doing COVID test. They have a 1-day turnaround and they have the capability of doing 50,000 tests a day. So if any of you listening are trying to find a source for a quick turnaround on COVID PCR testing, that may be a resource for you. Indoor air testing. Indoor air testing involves spore counts. And as I said earlier, I prefer the spore count. This is a spore counter from Zephyron, which most of the indoor air quality people use to do the counts. I keep one in my office so I can loan it out to patients. On top is a little cassette. You push the button, the air comes through the top of the cassette, down through the machine. The cassette on a membrane collects the spores. And usually you do 75 liters of air collection. and that's all automatically set on the machine down here. And then this is taken off the machine, the ends are sealed and sent to a lab for analysis. And as I said earlier, I prefer a lab that does 100% of the spore counts. I use Moody Lab here in Dallas, Texas. And I can send this home with a patient, tell them to close up the house, make sure the fan is running. So we circulate the air through the HVAC system as many times they are contaminated, and then run the counter and see if we have circulating mold spores. Now, this is not the end all to testing. As mold can grow behind the walls, particularly the stachy and chitonium, and emit the toxins, which is triclosan, and you pick that up in the individuals living in the house by running the mycotoxin test, but you don't pick up the spores. And that's because they're trapped behind the walls. I used the example of the skunk. If the skunk is under the house, you can't see the skunk, you can't feel the skunk, can't test for the skunk, but you sure smell the skunk, and the skunk odor is the toxin in this case. So it's significant. It gets through the wall spaces, through the light sockets, through wherever, and you breathe it and inhale it, and your body then bioaccumulates the toxins. In the air, you can also run the MVOCs, and I'll give you the source for that. I use that if we're having trouble isolating mold spores and we're looking for the volatile organics in certain spaces of suspected hidden molds. I know there's wipes and other things that can be done to pick up mold off of surfaces, off of floors, and I don't disagree with this. I think it shows what's inside. You just don't know what's been contaminated from outside, but it does give you a good idea if the house has been contaminated and what's there currently that the people are kicking around or breathing. Also, you can measure mycotoxins on the filters through real time, and that has been helpful if there's multiple systems in the house and you're trying to find out which HVOC system is contaminated or which part of the house is contaminated. You can run the mycotoxins on the filters and figure out which area of the house is contaminated. Heavy metals can be a complication, and Doctors Data does heavy metals, as well as if these people are having trouble with their memory, trouble thought process, depression, fatigue. Sometimes the neurotransmitters are not working right, and so we need to get that second morning urine to see what the epinephrine, norepinephrine, dopamine, mediators are actually doing and whether it's enough of it. I see numerous patients that are on antidepressants and their serotonin on the neurotransmitter test is low. So they do not have any serotonin or very little serotonin to be blocked so that it's increased. Therefore, you got to treat the patient with the precursors to serotonin to help boost those neurotransmitters so the medicines can be more effective. So let's take a look here at the elements of mold toxicity. We have allergy, and we'll talk about allergy, and then we'll go through the rest of this area of toxicity, infection, genetic factors. So with allergy, we're taught that there's different types of allergy. There's 6 types now. When I went to school, there was only 4 types. Then they found T-cell cytotoxic reaction and granulomatous reactions. The typical prick test, which the allergist does on the back, is only IgE mediated, and it's type 1 allergy. And that's what most of the standard allergists are concerned with. The mold allergy may be IgE, but generally not. Generally, it's type 2, cytotoxic, immune complex, or the true delayed hypersensitivity reactions. And then T cells get involved sometimes with that. So I use the intradermal skin test, which is the most accurate skin test for testing for molds, which is what the ENT group teaches, which is what the environmental medicine group teaches, and what Pan American Allergy teaches. And so we got the IgG, IgE allergy, and then we have an ID reaction, which is described in the literature as a pruritic eczematous dermatitis associated with, but usually distant to, another inflammatory or infectious skin lesion. So what this means is your skin's been sensitized, say on the left arm, you do a mold test on the right arm, and the left arm reacts too. So that's an area that's been sensitized. The treatment is frequently unresponsive to corticosteroid therapy, and the best treatment is to treat the provoking trigger. Now, the reason I bring this up is I'm going to show you a picture of something that many of you may recognize that everyone's kind of scratching their heads about, but I believe, from my experience, is related to mold. And this is Morgellons disease. This is a lady that came in that had been diagnosed with Morgellons. She had a biopsy which showed lymphocytic infiltrates, which they said was compatible with it. She had it on her legs, her face, and some on her chest. So it's the exposed areas. Nothing on her abdomen and nothing on her buttocks, just these exposed areas. And I've seen numerous cases like this. Morgellons is described as small fibers from the skin sores, lymphocytic infiltrates on the biopsy. She was mycotoxin, highly mycotoxin positive, mold antibody positive, excuse me, and her house had gross mold contamination. She was removed from the mold exposure, not treated with anything else, but over a period of 18 months, these skin lesions completely resolved. So it is my belief from this case and about 10 other cases that I've seen that Morgellons is probably due to mold exposure, and that the ID reaction has occurred, but in an inflammatory process. And that once you remove the patient from that, as they here, treat the provoking agent or remove from it, then their lesions clear. The patients really get concerned about the little streaky things coming out of the lesion site, so that they think they have parasites. They get the crawly feeling, which is the toxic effect of the nervous system on their skin. And so this is kind of a revelation to me as I've gone through the last couple of years dealing with some of these complex cases. Now we'll go back to the skin test. This is testing with the intradermal skin test. You have bottles that have a concentrate, and then they're diluted 1 to 5, or some people dilute them 1 to 10 dilutions. So you have stronger, weaker, 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 weaker. And what you do, you take a little bit of the solution up in the syringe, make a wheel, you put this under the skin, make a 4 millimeter wheel, and use a lesser dilution, which is 6. Then you go stronger, 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 and you see where a wheel is developed. If it's no wheel develops, then it's a negative test. If a wheel develops and then it's progressive, so you go from 4 millimeters to 7 millimeters to 9 millimeters, the 4 to 7 is a positive test. So they have a number 3 dilution reaction. And molds test very, very well this way. Many of my mold exposed patients have 4, 5s, and 6s as a response. So they're very, very sensitive to mold on the intradermal skin test when they will be negative on the prick test. This is the Pharmagon IgG test. This is my mold panel that I use. All these can produce toxins. And this is an example. We see that Aspergillus fumigatus is a 3. The highest ranking is a 4, class 4. You have Phoma beta, which is a 4, so they had lots of exposure to this mold. Chitonium and Stachys are 3s. So this gives me a good idea of what their exposure is and what their immune response is to that mold. So we're able to connect the skin test for sensitivity with the IgG mold test for exposure, with the spore count test for indoor exposure, and make that chain of connection that they got exposed in the building, in the house. Their immune system reacted to it, they developed allergy, and they had mold toxins that relate to their exposure. So we see that the Aspergillus produces the toxins that we measure through real-time labs. Then we look at the toxicity part, and we know that these mycotoxins are neurotoxic, as we talked about, affecting the brain, the peripheral nerves, the cranial nerves, which like the vagus nerve, which goes to the stomach. They're lipophilic, so they stick tightly to the cells and are hard to get out of the body. They may alter DNA and RNA. They upregulate or downregulate the immune system, and they affect the mitochondrial cellular function, which causes decrease in ATP and the fatigue. So most of you are, I'm sure, familiar with real-time labs and the mycotoxin panel. This is just showing you what a panel looks like. I encourage you to do serial testing. It helps to know what is actually going on with the patient. If they get exacerbation of their symptoms, you know that they've either gotten re-exposed or they're mobilizing mold toxins from their system and causing the symptoms. So in this example, we see that this person initially came in, had a very high ochratoxin, 12.5. Aflo was up, trichocythine was up, glial was up. We were treated over, this is a 1-month period from February to March, and used hyperbaric. It dropped precipitously. They were feeling a whole lot better, and they went out and they got re-exposed back in April, and it jumped back up. So it really helped to define exactly what was going on in that individual, and then realize that, hey, it's the toxin that's there. The history showed re-exposure. This could have been mobilization, but in this case it wasn't. It was actual re-exposure. This is a spore trap report. And in this individual, this is the child's bedroom over here on the left, the number 4, and it showed 23,200 Aspergillus penicillium, which is tremendous amount, and it was 100%. Usually in the outdoor air, Aspergillus penicillium is less than 10%. So when I look at the percentages as well as the spores per cubic meter to determine whether it's abnormal, I've seen people with 500 spores cubic meter total with, and they're told, oh, there's no problem, you have a low mold count, you're below 1,000. But 80% of it would be Aspergillus penicillium, or it'd be 60% Aspergillus penicillium with 20% Stachys, which is down here. So that's a contaminated, and the people would have mycotoxins when you measure their urine through real time. Here's outside control on this same time interval you see the outside control, 133 Aspergillus penicillium, which is 4% of the count. And the outside count was 3,130. So this is a grossly contaminated residence where the kids were getting the main part of it. The kids were not doing well in school. They couldn't think. They were misbehaving. They would stutter. They would get words mixed up. Just a tremendous problem with the neurocognitive effects. The master bath had 4,900 Aspergillus penicillium in it. Under the kitchen sink was 4,000. And the children's bedroom vanity sink, where the leak really was 51,000 spores of Aspergillus penicillium. So the spore counts can really help you find where it is. Visually, you can look first. The indoor air quality guys are experts at this to help, but many times they only look at total spore counts and say, oh, this is not a problem because your spore count's not high, but the percentage and the type of molds are the important things. Chitonium, Aspergillus penicillium, Stachy are the big ones for indoor mold contamination. This is a mycotoxin volatile organics, the MVOC test done by Prism Analytical. It's an indoor air quality home survey, they call it. You can order directly from them, or the testers also have availability of this test. This is an example of the test. Here it says your total MVOC level is 12. It should be less than 8. And in this lady, we'd done spore counts in her house, couldn't find exactly where it is, except spore counts were slightly higher, but less than 500, close to her bathroom wall. We did an MVOC there. It picked it up at a greater than normal amount. We tore into that wall and found out that that was a false wall, and there was another wall in between, and there was Aspergillus penicillium growing on that wall we could never see. So it was a real help in isolating where to look and where to find the mold. This is the family that we saw with that high mold count that came in. You can look, as you look down, the ochratoxins all seem to be the same, or that they're all present in kind of the relative same amounts, except different family members have different amounts as they live in different areas of the house. And the same way with the aflo, the triclothacine, and the glio. Now, they underwent hyperbaric, and from 4.6 to 4.24, we see it pushed up the ochratoxin, pushed down the ochratoxin this person, but this person was still symptomatic, so they did more hyperbaric, and it pushed it back up to 4.1, and that was a deeper area, and that was the mother. She was having neurocognitive troubles, had been prior exposed to molds in a different living situation than the current one, and so she was one of the sickest. Her daughter, which lived in that really contaminated area, had the same type of problem of really getting rid of the toxins. We pushed it down initially, but then it jumped back up, and she was still having neurocognitive problems. The father, we pushed him out, and he was doing a lot better symptomatically. And since he was doing better, we didn't go ahead and retest that. But this shows that the tests are pretty consistent throughout when you look at families and you look at what is going on with them and relating to their symptoms and how well they feel. So now we're going to talk about infection. Infection occurs in the sinuses and the lungs. This is an example of the microgen test from sputum. and we grew out Aspergillus penicillin. So this person actually had aspergillosis, pulmonary aspergillosis, and was needed to be treated aggressively with antifungals at that point. I've seen this in nasal smears as well. They can have secondary bacterial infections. Over here we see that we did not detect Haemophilus, we did not detect strep, we did not detect candida, we did not detect Pseudomonas. So we understand what we didn't get, and the main thing was 98% was Aspergillus niger, and that was treated. So how do we treat these patients then? We've gone through the assessment, looking at the house, looking at the individual, making sure they do not have other underlying systemic disease processes. And even if they have immune disease processes, you know, over 90% of lupus is triggered by something, by an environmental factor, and the textbooks support that. So we always want to look at what is the underlying triggering part of it, and is it still there and present, and what can we do to treat it? Back in the 90s, I saw a lot of organophosphate poisonings from Dursban in the house. Now, Dursban was unusual because it would damage the individual, cause neurological problems, and then leave. And so you were just left with trying to treat the nervous system and not try to get the toxins out. In this case, the toxins remain in the system, and we have to force those out so the body can heal to regain health. So if we find a person who's been exposed to mold and they have mold toxins in their system and they're allergic, we got to get them out of that environment and get them into a safe environment. People have tried and say, no, I don't want to move out, I don't want to do this. They stay there, and all they do is get sicker, or they don't get well. So I encourage them to move out, look for family, friends, wherever they need to go. If they've had a recent water leak or any water leak at all, and it's their home and they have homeowners insurance, I encourage them to contact their insurance company to help them repair it. And the key issue is that I've had a water leak, not that you've had mold. Mold is secondary to the water leak, because most of the insurances don't cover mold, but the water leak was truthfully the initial cause. So insurance companies, a lot of times will pay for them to move out, pay for it to get fixed, and then they have a post-remediation test to prove it's safe, and then they move back in. Now, the remediation test should be done before they remodel. It's done after the tear out. So if it's still positive, then they need to do more searching, more remediation until it turns out to be negative. If they're moving to a new place, they need to make sure the new place is safe and have testing done on it. So the second is how to get the toxins mobilized and out of the system. We know they go through the liver, they go through phase 1, phase 2, detoxification. Different people can excrete more readily than other people. We know that some have methylation problems, some have acetylation problems, some have gluconation problems, and some have oxidation problems. And so 80% of the toxins are excreted through the kidneys. So with this, we use nutrients, as we're going to talk about, and then a few binders that bind up what residual is in the gut. But I don't overdo the binders because you bind up all the nutrients and you're defeating yourself. And then I use hyperbaric oxygen therapy in an intensive mechanism once a day or twice a day to force the Krebs cycle, the mitochondria, to create healing, kick out the toxin, mobilize the toxin, heal the neural cells, and then excrete it. And as you've seen in some of the examples, within a month, which is usually 40 hours of treatment, we dramatically decreased the mycotoxins that we measure in the system on excretion. If they need antifungal treatment, I use a combination vancomycin antifungal medication called Bix spray. It's from a pharmacy I get here in town. Many of the compounding pharmacies make up something similar as a nasal spray. Use oral antifungals when needed, and if severe, use IV antifungals treatment. Supporting treatment is very, very important. It seems that the gluten-sensitive people have much more trouble excreting the mold toxins and tend to retain it. And at this point, I can't tell you why. Maybe some people know what happens genetically with that, but I use a lab in Terrell Lab, looks strictly at the genetics of gluten intolerance, sensitivity, and celiac disease. And if they have those genes that relate to this, it's important they get on a gluten-free diet because that just sets up inflammation and confuses the detox picture with the mycotoxins and does not help the body's healing. If they have other food reactions, and many of them have dairy sensitivity, some of them have nightshade sensitivities, I use a rotation diet. And that's a 4-day rotation where you do not eat the same food but once every 4 days. You can Google rotation diet on the internet. It's there. You can contact me and I can get you a rotation diet. The elimination diets are great if you know exactly what foods a person reacts to, but most of the time we do not. And a lot of times they're hidden foods. And so if you isolate and eat only 1 or 2 foods a meal and do not repeat those foods but once in every 4 days, and you separate the food families out every other day, then a person can sort out on their own what their food reaction are into what specific foods. Sleep is important, and if they aren't sleeping, they need sleep for restoration of the body. So I use Alpha Stem to help with the sleep. That's out of Mineral Wells, Texas. Check the neurotransmitters to make sure that they are in balance, and that's through doctor's data. And if they have sleep apnea, I use a TAP device, which is a mouth guard device that has an upper and lower piece to it with a attachment in between that's adjustable to hold your jaw out so it doesn't flop back and block the airway off. Look at the QEEG to see if there is abnormal brain waves once we get the initial toxins out and get everything calmed down. Some people still say, well, I'm having some neurological problems. I'm anxious. I'm still not sleeping well. We look at biofeedback, and then Annie Hopper's DNRS system has helped some people regain that limbic control in their brain. So the healing process involves allergy immunotherapy, which builds up blocking antibodies in the system. It's the only thing that develops tolerance to allergy. So you use allergy shots, allergy immunotherapy based on the intradermal testing. I use hyperbaric oxygen, and you have to do this. It's an art because you can do way too much too quick and force too many toxins out at once and make the people really sick and they won't come back, or you're really fighting an acute problem and trying to get their nervous system calmed down. They can't sleep, they're very anxious, they're irritable. So we ramp up the hyperbaric oxygen as they tolerate it, usually starting off with one 1-hour session a day at the lower atmospheres, but then push the atmospheres to get the toxins out. The low pressure chambers are fine for maintenance a lot of times once a person is healthy, but it takes 2 atmospheres, 2.4 atmospheres to really mobilize the toxins from the system, and that's breathing 100% oxygen. I have a liquid oxygen container like the hospitals have outside. We pipe that directly into the chambers. They breathe 100% oxygen. and under pressure in the individual chambers. Then on those people that are immune deficient, that have combined immune deficiency or acquired immune deficiency, IV gamma globulin is used to help support their immune system. The nutrients, the main ones I use are glutathione, lipoic acid, CoQ10, vitamin C, B complex, and then maybe some biobinders, a little charcoal or a little clay once a day to help bind whatever comes out in the gut. Remember, 80% of the mycotoxins in your body are excreted through the kidneys. If they are crashing or having really acute symptoms, some people respond to IV glutathione, others to vitamin C IV, or a combination of Myers cocktail and glutathione. Many of you may use different of the herbs, and I found this essential to help calm down different symptoms in the people, support the liver, the kidney, or the lungs. Now, in my patients, so many of them are food allergic that all the herbs count as foods, and so they can react to an herb just like they react to wheat or corn or gluten or dairy. So I have to be very careful with using herbs. So this is an example of hyperbaric. This is a hard-sided chamber. It has no electrical parts to it. It's all pneumatic. There is a TV on the outside, so the patients lying inside can watch TV, a movie, and keep them occupied for the hour to hour and a half that they are in the chamber. The treatment pressures are typically from 1.5 to 2.4. It has many, many actions, but it turns off genes related to pro-inflammatory hormones and cell death. It turns genes on to growth and repair and anti-inflammatory genes. And then the protocols may vary, as I've talked about, depending upon the patient's tolerance and how toxic they are. This is a type of low pressure chamber that usually has an oxygen concentrator with it. So you don't get 100% oxygen in the chamber completely. They're breathing whatever it puts out. It's putting you under pressure. So you do get some increase in oxygen into the cells and into the blood vessels and into the plasma, but not nearly like this where you increase the oxygen delivery 10 to 15 times to the tissues with the hard chamber. So this is a case study of a person that had mold exposure and was treated with hyperbaric. She had a contaminated house, one in East Texas and one in Colorado. The blue line here at the top is showing the hyperbaric treatments. Anytime you have a rise in it, and the blue highlight is where she received hyperbaric treatment. So when I saw her, she had some elevated mold toxins, and this is over here on the left. Hyperbaric was started. We see the mold toxins dropped way down close to zero. She was feeling well. However, we continued hyperbaric because she still had brain fog, she still had fatigue, and we saw that as hyperbaric continued, the glial toxin shot up, which is the yellow line, which is related to Aspergillus penicillin. And sure enough, we knew that she had Aspergillus penicillin in her house. And so this is that second layer of retained mold toxin that we saw. It also, ochratoxin, which is related to Aspergillus penicillin, jumped up too, but not quite as much. So we see that the two jumped up. They were pretty much in concert with each other while she was doing hyperbaric. We stopped here and remeasured as she was feeling, said, pretty well back to normal. And sure enough, they were all down low levels. So then we come over here to the next time, which was December of 17, and this was May of 17 back here. So we 6-7 months. We measured her. She was still feeling pretty good at that point, came in for a checkup, had some symptoms. Her ochratoxin was up a little bit, but everything else was down. She came back, said, oh, I'm feeling worse. We remeasured her. We could see everything was high. Started hyperbaric, did it here. The toxins dropped down, then they jumped back up again, and then they went back down as her body excreted it, and she felt better. She had a lot of things going at this point, so we got in as much hyperbaric as we could and then let her body heal. She went to Colorado, felt better, and then got re-exposed. Same thing happened again, hyperbaric. Toxins got back down to 0. And then they jumped back up over here when she got re-exposed again and treated again. She did well for a long period of time and then just recently got re-exposed. So this shows a couple things. One is that hyperbaric is effective in really mobilizing the toxins and people excreting them with the use of the antioxidants that support the liver and its excretory mechanisms, metabolic processes, and that people do get re-exposed, and it can be documented, and it correlates with the symptoms and relates to the actual time of the re-exposure. So in my cases, I find that serial testing is important in the treatment and helping the patients understand what's going on, because it's really scary for them when they say, man, I can't think again. I'm just not functioning well. I'm having a hard time taking care of the family, or I'm having a hard time work, or I can't maintain the quality of work. And you repeat the mycotoxins, and sure enough, they're back up again because of what their situation is. And I have this with school teachers in schools. I have it with people to stay at home and work. I have it with students in the school. I had one girl that every time she went to school for any period of time, she'd develop a seizure and pass out. She never did this at home, never did it any place else. Measured the school, sure enough, in her area of the school, there were severe mycotoxins, and we measured her levels, and they jumped up at the time she was exposed. So serial testing is important. We've run quite a bit over our hour, and I hope I haven't bored you, and this information has been helpful to you in my experience. This is the list of resources. So we have real-time labs which measure the mycotoxins and does the other tests on the filters, on the wipes, and so forth. Moody Labs does the spore count analysis that I use. Zephron is the spore counter. GD air testing does air contamination. So if you need to find out what other solvents or what other air contaminants may be there beside the mycotoxin ones, GD air can help you. I had a whole family that was sick, and come to find out they were exposed to phosgene. And I said, how in the world did phosgene get in their house? That's a war gas from World War I. Well, Freon, under a flame from natural gas, which was the hot water heater, which was downstairs, creates phosgene. And so we found phosgene and got them out of the house. They were a long time recovering because that's a strong neurotoxin. Serolabs does the IgE testing. Intero Labs does the genetic testing for gluten sensitivity. This is a repeat, just forget that. This is the true one right here, Intero Labs. HLA testing for gluten. Microgen Labs does the PCR testing and does the COVID testing. Genova Diagnostics does the detox panel, which I use to help sort out the phase 1, phase 2 defects from whatever the patient has, whether it's acetylation, gluconation, or oxidation problems. Las Colinas Pharmacy produces the Vicks. Sleepwell Solutions produces the TAP, the sleep device. I use a Nonin wrist ox pulse oximeter, which records overnight to see if they are desaturating, and then they can get a whole sleep study, but I keep that in my office as a computer program right on that you put on your computer and then read it. And then the book Damp Indoor Spaces and Health, published by the Institute of Medicine, is a great book to have. You can get it online, and I'm not sure it's in print, but you can print it online, and it goes through the toxic part of it and what the different mycotoxins do, how they affect RNA, DNA, their different toxicities. And there's a lot in the literature on this also. Just one thing back on hyperbaric. This is the Krebs cycle. The red dots are all where oxygen is necessary for the different part of the Krebs cycle. You can see it's the most prevalent. So when you force oxygen in the tissues, it stimulates the whole Krebs cycle, the energy cycle, and regenerates the little mitochondria so that people can recover from energy and regain their health. This is just a slide, who I am, my 2 websites, and how to get a hold of me. If you need information, info@johnsonmed.com. Thank you for your attention. Matt, thank you.
Thank you, Dr. Johnson. That was great. I definitely learned a lot. So we definitely have some questions here. You have a couple minutes, Dr. Johnson, to answer some?
Oh, I sure do. Let me see if I can get my video on here. Okay, I'm ready for questions.
Okay, so the first question, I think that you kind of answered it. So which lab does the Saccharomyces, IgM, or IgG testing? So I know you talked about IgG, or I don't know if you mentioned the IgM in your last slide there.
Yeah, the Saccharomyces in LabCorp and in the panels, it comes as a group. It's a panel, Saccharomyces panel, IgG, IgM. IgM typically shows current problems with it. IgG shows past problems. So if you have both positive, I'm concerned about what is going on right now. If it's just IgG, I know that you've had inflammation in the past from it. Can you turn on my video?
I can't do it, but it's on your bottom left of your screen here, next to where your mute button is. There should be a video button.
Okay.
There's no video there.
Hover over that green thing.
Oh, okay. Here you go. It says I cannot start it because you have stopped it.
I have stopped your video?
That's what on my end it says that.
Okay, let's see here. Hold on.
Hit stop share up there and see if that helps. Now hit start video.
No. Well, that's okay. We'll go ahead with questions. How do I get back?
Okay, so I made you the host. You should have full control over everything now. But
Okay.
okay, so next question is, so talking about glutathione challenge. I mean, I've seen this question. I mean, almost every time I give a talk, I hear this question. I'm curious to hear your thoughts on it. Glutathione challenge, dose, time. I assume this is like means like before like doing like initial mycotoxin assessment.
I think I don't do many glutathione challenges, but I've seen people that do where they use anywhere from 1,200 to 2,400 for 3 or 4 days and then repeat the mycotoxins. You have to just see how people tolerate it. I usually get people on 600 milligrams a day of lipolyzed glutathione. I typically use the Ready Store brand, but most of the lipolyzed work fairly well. And if you're going to do the challenge, because my patients are really sensitive, I start them off with 600 and then I work to 1200 and then maybe 1800 and do that for a couple of days, then collect the urine.
Yeah. So, I mean, I kind of like follow Dr. Nathan's protocol where it's very similar. So he does 500 milligrams twice a day for 5 days. But if any time during that period, the patient starts feeling like dramatically ill, he tells them to stop the protocol and to collect immediately then, because that usually indicates mobilization of the toxins. So it's I think that there's definitely some like different ways that different practitioners go about that.
Yeah, exactly. And all those different ways work. I find that the hyperbaric really forces it out and patients feel better as they're doing it most of the time. So we're getting the healing part of it, just not a mobilization part. But those who don't have access, then the glutathione challenge does work and show that, yes, it's stored and that you're sick because of a reason.
Yeah.
And that it is stored in your body.
Which lab utilizes the Pharmagen antibody?
That is the Cyril lab out of Waco, Texas.
Okay.
Yeah, Pharmagen is the oldest ELISA testing lab and produces the IgG antibodies. So I've stuck with that. It's been reliable for me.
Okay. Are there different treatments depending on which molds are present?
I find that I have seen not much different as far as really getting too didactic about which mold toxin is present. Now, we got to realize if we're treating mold allergy, I treat each mold as a specific allergen, and we test all those molds. So we test Stachy aspergillus, and the mold mixes for the outdoor molds, because once they react to indoor molds, they react to the outdoor molds. So I treat all those specifically with immunotherapy. As far as the toxins go, I treat that all the same way, that the body, I believe, will select what it can handle at the time it handles and mobilizes what's there. And when I see all kinds of random mobilization with hyperbaric, sometimes they'll mobilize triclothacine first, sometimes they'll mobilize ochre first, sometimes they'll do it all together. I've not seen a pattern. So I'm not got carried away with a bunch of different protocols for if we see triclothacine in one and ochre toxin in another.
Okay. Yeah, I mean, I kind of like, it's kind of how I talk. I mean, that's the common mix.
I don't see that it makes the body handle it, and you provide the nutrients for the liver to process it. It will select its own time and place for it. You just have to encourage it.
Yeah. I think one question is sauna also has been shown to remove mold toxins. What's your thoughts?
It helps. I've done sauna for years and years and years, and originally started with the solvent exposed patients, like the toluene, the xylene patients. Those are very small structured compounds which are highly volatile and are not very lipophilic, and so they come out really readily with sauna. The more lipophilic ones, the more complex structures like the mycotoxins are a lot harder to get out and takes a lot longer with the sauna. And so
I would agree with that. Yeah, I mean, so I did a study with Stephen Genuis, and we saw kind of the similar results where, yeah, the smaller molecules that are more water soluble come out through the sweat, but there's really nothing published right now showing how sauna helps in mycotoxin mobilization.
Right, because the liver has to process it, and the nutrients help the liver, support the liver, and the hyperbaric helps liver metabolism function, so it speeds all that process up.
There's a question here about ERMI testing, or let's see here, or which other type of home testing is best. I know there's a lot of different companies out there. I mean, I'm kind of biased. I really like the real-time labs test. Now we have the EMMA test, which is a competitor of the ERMI, but there's a lot of similarities. The ERMI and the EMMA both do the spore DNA portion, but the EMMA is the only one that does the mycotoxins for the home. So, like you said, for like your skunk analogy, that can be like really important when, especially for Stachy, when you have Stachy stuck behind walls. Being able to like measure mycotoxins is important.
Yeah, I agree with you. The one thing, if patients are going to do self-testing, they need some help in understanding what they're dealing with. And depends on how much they leave their windows and doors open, depends on what you get inside. So sometimes I've seen patients really run astray by trying to self-analyze one of those self-tests. Now, if you find mycotoxins on one of the self-tests, then that is significant, because mycotoxins have to come from indoors. Outdoors, it's to the loot, and it's a chemical that's stuck because of excessive chemical in that structure. Does that make sense?
That makes complete sense to me.
Yes. So
let's move on to, so the next question was, which binders do you typically like to use?
I have used cholestyramine some in low doses, but it really causes a lot of GI upsets in a lot of people. The clay work fairly well in small doses. I use it just in the evenings after everything else is taken, because it binds up the nutrients. And the same way with the charcoal. And you're only working on a very small part of the toxins. Most of it has to go through the liver and out through the kidneys. So that's the 80%. So I really focus on that. But if they're having some GI complaints, I look at foods first. You can use some binders at night, as I've talked about, a little clay, a little charcoal, and that may be a help.
Let's do one last question here. Do you have a suggestion of how to make a low pressure hyperbaric effectiveness therapy? Would you like stay in longer, more often? Is there any way to like make it work?
Well, the longer you stay in it, the more oxygen you deliver to the tissues. So staying longer typically makes it more effective. But how long a person can actually stay in one is a problem. And so the tighter bound the mycotoxin is, the harder it is for low pressure to help. That's why I use it for maintenance once they get well. I go back to the story of one of the patients I had that had chronic repeated exposures in this huge house she lived in Arizona, because it had a tile roof with multiple angles and kept leaking, and finally got her healthy. And she said, well, I got to go get my knee replaced. That she had a total knee done years ago and it was loose. And she said, I want to come back and do hyperbaric to help it heal, so I go on vacation with my family and really function. I said, fine. So she said, I want to do maximum hyperbaric. So got her knee done, did well, feeling good, came back, put her in hyperbaric, and I pushed it to the max at 2.4 atmospheres. And I did 2 treatments a day. 5 days into that treatment, she says, I feel horrible. I feel just like I got exposed to mold again. I ran the mycotoxins, and they're higher than they had ever been that I'd seen in her. We mobilized another layer with that increase in pressure. So with that, I learned that you can have different layers of it, and that pressure is probably important in trying to get all the toxins out, that you have to have that increase in pressure. So I call it the kind of final rinse with the hyperbaric to push that toxin out. And that's why at the end of most of the people that are doing well, I push the time and pressure to what is safe, but to the max.
Well, I think we're going to end it there. Thank you, everybody. So this webinar will be put on our website probably sometime early next week. So if anybody has any other questions, please send them to Real Time Labs, and we'll try to answer them as much as we can. Thanks, everybody.